Well, thank you very much. Good morning, everybody. It's wonderful to be in such a beautiful venue. I just wish the sun was shining. But thank you very much, first of all, to the Congress organizers for inviting me to talk here today. I also come from a very beautiful country and from Cape Town. That is Cape Town there, and that's Table Mountain. And this is the big football stadium that was built for the World Cup, which was held in South Africa. Unfortunately, it now stands empty most of the time. So, I'm talking on dopamine and psychosis this morning. And when you see that title, I'm sure you're thinking, oh, no, not again. We've all heard so much about dopamine and psychosis. But let me tell you, I'm hoping that I'll be telling you some much more interesting and much more relevant and very new information that is of critical importance to us as clinicians in psychiatry. So we started with dopamine when we were looking at the neurochemical components of schizophrenia, and we've spent a lot of time looking for other possible mechanisms. And it seems as if the circle has come around, and the more we look for alternative mechanisms, the more we come back to the fact that dopamine is the key, and it's the core neurobiological issue in schizophrenia. These are my disclosures, and what I'd like to talk about this morning a little bit is around the neurobiology of schizophrenia, the contemporary dopamine hypothesis, and why we as clinicians need to take cognizance of this contemporary hypothesis. Emil Kraepelin was a remarkable person, and he was the person who best described the chronic and deteriorating course of this illness of schizophrenia. And this is a photograph taken from his book, which was before we had any effective treatment for the illness. And you can see the absolutely devastating effect of the illness on patients when we don't have treatment. So these are all chronic schizophrenic patients. You can see with severe catatonic symptoms. This guy with his fatuous grin would be hebephrenic or disorganized schizophrenia. And the one hiding away here, obviously, is apathetic, prominent negative symptoms. So this is the spectrum of schizophrenia and the incapacitating consequences of the illness. And then along came Jean Delay and his group in France. About 60 years ago, they introduced the first effective treatment for schizophrenia, and that was chlorpromazine. And since that time, we've had the introduction of a whole host of newer antipsychotics. Paul Janssen from Belgium was one of the innovative neuroscientists who introduced haloperidol, which has been a drug that has been widely used for a long, long time. And from that, risperidone and paliperidone, and of course a whole lot of other agents that have been developed in the treatment of schizophrenia. And then you get the skeptical psychiatrists who say, but hang on a second, chlorpromazine is actually a very good antipsychotic. And there's really not much difference between chlorpromazine and the new generation of antipsychotics. But I think, in actual fact, there have been steady and important progressions, and our expectations have probably been too great in research development. And the advances with the new antipsychotics have been small, but they've been substantial, and that's important. So antipsychotics, the old, the new, whichever one you look at, they all have one thing in common, and that is that they block striatal D2 receptors. And this was the Karolinska Institute's very famous series of studies showing a curvilinear relationship between the dose of antipsychotic medication, the plasma levels, and the D2 receptor occupancy in the striatum. And we find that maybe somewhere between 70 and 80% is the critical therapeutic window. And if we can target our drugs there, we're able to get antipsychotic effect, and we're able to avoid extrapyramidal symptoms. So the dopamine receptor was and has been and still is a focus of great attention because, as I say, all of our drugs have this effect at dopamine. There's a massive amount of research going on in schizophrenia today. And the two greatest areas of attention and interest, of course, are dopamine and genes. This is where we're focusing our attention. And the geneticists will tell us that they've discovered the causes of schizophrenia, the genes. And when I started out, when molecular genetics first appeared maybe 15 years ago, we were told we're going to discover the gene that causes schizophrenia. And sure enough, we did. We discovered neuregulin. But then we discovered another one, dysbindin, and another one, and another one, and another one. And so we find that it's not easy. And then in fact, we're dealing with a whole lot of genes, common genes, with small effect. And these are the contributing factors, the so-called single nucleotide polymorphisms that increase the risk of schizophrenia. Occasionally, there's a spontaneous mutation, a copy number variant, which is much more striking and has a much greater impact, and on its own may predispose to schizophrenia. So when you look at the new genetic studies in schizophrenia, you'll find that the list of authors is almost as long as the actual manuscript, because what is happening is that we know that to get good results in genetics, you need as many DNA samples as you possibly can, and people are pooling their results, and these are pooled results from individuals. The who's who in genetics in schizophrenia have all put their genes together, their DNA together. And what we're finding is they've been trying to replicate the previous findings, and they in fact are replicating some of them, but every time they do an analysis, they come up with new genes. And in this recent publication in Nature Genetics, which is an amazing journal with an impact factor of, I think, 38, they concluded that we estimate that 8,300 common SNPs contribute to risk for schizophrenia. And these are SNPs that you and I share, but somehow in combinations and in combinations with environment, they increase the risk. And that's very confusing because all of these genes seem to be related to different functions until a group of Hungarian neuroscientists posted a letter in the American Journal suggesting a possible link to a lot of these susceptibility genes. And that link is AKT. The AKT pathway has been proposed as a link. So if you're wondering what AKT is, there it is. AKT is involved in multiple functions in the body. It's involved in glucose metabolism, apoptosis, protein synthesis, and neurotransmission. It's one of these compounds, protein kinase, that has multiple functions. And the one we're interested in is AKT-GSK. Why should we be interested in that? Because it focuses on dopamine and on the dopamine D2 receptor. So AKT-GSK system is the downstream intracellular signaling system for dopamine. And this is something like how it works. There is AKT, and it, by means of phosphorylation, inactivates glycogen synthase kinase. That's its function. However, when dopamine binds to the D2 receptor, it sets off a cascade of events. There's a scaffolding protein that recruits AKT and a phosphorylase which deactivates AKT and which is no longer able to phosphorylate GSK. So GSK is now free to do whatever it does. And this is important because we know that antipsychotic medication has an effect on this system, and we know that psychotogenic medications also affect this area. And in fact, it was a group in London, at the Institute of Psychiatry in London, Simon Lovestone, Robin Murray, who have proposed, I'm so sorry, that this is a possible lesion in schizophrenia. So when we look at the neurobiology of schizophrenia and we try to put the genes and dopamine together, we get something like this. We know that early environmental factors are important and neurodevelopmental genetic factors are important. We know that there are subtle symptoms in the premorbid phase of illness. Stress and isolation plays important. And this is a critical stage of the illness of schizophrenia. The prodrome. And here we know that perhaps a different set of neurotransmitter genes come into play. And we also know that one of the most important extrinsic risk factors in psychosis is substance abuse, particularly cannabis and methamphetamine. These are agents that are strongly associated with precipitating schizophrenia. So neurotransmitter dysregulation occurs here in the prodrome, and by the time patients present to us with the first psychotic episode, you can see that the illness has progressed over a long period of time, and here we have florid dysregulation. So back to the Institute of Psychiatry in London and a different group of researchers. Oliver Howes, Kshitij Kapoor, Phil McGuire have done some amazing imaging work using PET scanning. And this is what they find. They've been looking at presynaptic dopamine D2 synthesis, and they found that in patients with schizophrenia there was increased presynaptic synthesis. The fantastic thing is they looked at prodromal patients, the so-called at-risk mental state patients, and they found to also, as I said, in the prodrome, this is the start of the neurotransmitter dysregulation. You can see that there's elevated dopamine synthesis. The fascinating thing was, in this group of at-risk mental state patients, these are the patients who have about maybe a 30%, 40% chance of transition to psychosis in the next 24 months. It was the patients who became psychotic who had the elevated striatal D2 synthesis. So this group of Howes, Kapoor, etc., have now put together for us the new version of the dopamine hypothesis. Version 3, the final common pathway. And it goes something like this. This is the dopamine receptor, and they say that multiple intrinsic and extrinsic factors can combine to increase dopamine synthesis, and that works via our salience mechanism to cause psychosis. So the aberrant salience hypothesis says that a hyperdopaminergic state interferes with our ability to focus on what is relevant, what is important, and what is logical. And that is the aberrant salience hypothesis. And antipsychotic medication, as I say, all have in common. They block dopamine release and they block aberrant salience, and so by that mechanism they block the psychosis. And the important, and to me the fundamental issue here, is that we're not curing a psychotic illness. We're putting a dampener, we're putting a lid on the psychosis. So that means there's a very direct relationship between D2 blockade and effective dampening of psychotic symptoms. There's a very direct relationship between D2 blockade and the expression of psychosis. And that is why we as clinicians should be focusing all of our attentions on providing continuous antipsychotic medication. Still with Dr. Kapoor, but in his days before he went to London, he was in Toronto, and he and Ofer Aged did a fantastic study where they did a meta-analysis of acute clinical trials, and they disproved what we had believed for a long time. When I started out in psychiatry, I was told that antipsychotics have a delayed onset of action and that you have to wait a long time before they have an effect. In fact, we know that's not true, and the opposite is true. When we give our patients antipsychotics, the effect is rapid. They work rapidly, and within days you see a good reduction in symptoms, and within the first 2 weeks and 4 weeks, that's when most symptom improvement occurs. Sure, they continue to improve up to maybe 6 months or so, but the most dramatic improvement with antipsychotic treatment occurs within the first few weeks of treatment. And this is what they used as the basis of their aberrant salience hypothesis. The direct relationship, you put the lid on the symptoms and you get a rapid improvement. We ourselves did a study looking at a large sample of first episode patients, looking at something similar, and also we found that in first episode patients, first treatment, 80% of our patients achieved clinical response within the first few weeks of treatment. So antipsychotics work rapidly. And if that's the case, and if we believe in the aberrant salience hypothesis and the lid on the psychosis, so you put the lid on and the psychosis resolves rapidly, then the opposite should also be true. If you take the lid off, we should expect a rapid resurgence of psychosis. And this is where our own group have focused our attentions now. We've been looking at the nature of relapse and some of the neurobiology of relapse, and we came up with some rather unexpected findings, and I think very important findings that I'd like to share with you. The first point is, we didn't find a subset of patients who, when you stop treatment, never had a recurrence. Virtually all patients, even after a single psychotic episode, relapse when treatment is discontinued. And this is taken from a study where we treated first episode patients for 2 years, where they did very well. And for the patients who were in remission, treatment after 2 years, we offered them the option of treatment discontinuation. And this is what happened. You can see that soon after discontinuation, they were all treated with long-acting risperidone. Even within weeks after discontinuation, there's a rapid onset of recurrence. By 12 months, 80%, and by 24 months, 94% of our patients had experienced symptom recurrence. Is that different from other studies? There are several other studies that show a similar result. And also, if you look at treatment guidelines, they'll tell us how long should we treat a first episode? 12 months, maybe 24 months? Well, in fact, it doesn't seem to make any difference. So the longer you treat a patient before you discontinue treatment, there's no reduced risk of relapse. These are the studies that have been published, and you can see that even when patients were discontinued treatment after a short period of treatment and hours, there were very similar results in terms of relapse. And relapse is something that we shouldn't be taking lightly. Sometimes we psychiatrists have a fairly laid-back attitude towards relapse and say, oh, well, I can afford to let my patient have a relapse or two, then maybe he or she will recognize that it's important to take medication. But in fact, the consequences of relapse are enormous, potentially catastrophical, huge psychosocial consequences, harm to self and others, jeopardizing relationships, employment, education, diminishing personal autonomy, and contributing to stigma. So very good reasons for us to try and prevent this from happening. Something else about relapse that we discovered is that, as I said, it can occur within days of treatment discontinuation, and there are no effective early warning signs. So we are unable to predict which of our patients are going to have a relapse when these treatment occurs. We are unable to identify early warning signs. And this is the same study, and what I'm showing you here are the survival curves for loss of remission station, which is the blue one, loss of remission status, and the red one, orange one, is onset of relapse. So with the second psychotic episode, which we're seeing here, it's unlike the first one. We don't have a prodrome. We don't have a gradual onset of psychosis. We have patients remaining in remission and then within a day or two, very often, suddenly becoming floridly psychotic. And we can't predict these early warning signs. And then the other thing is, apart from the psychosocial consequences, there are biological consequences of relapse. And you've all heard about the toxic psychosis hypothesis that states that as long as patients have active symptoms, it indicates an ongoing progressive degenerative brain disorder. Well, how true is that? We looked at that, and we found that, in fact, there is some evidence to indicate that that is the case. This is a fantastic study that was conducted in the Netherlands. It was a 15-year follow-up study of first episode patients. And what they looked at was the consequences of relapse. And the authors of this study pointed out what they described as a striking finding. And they said that after each relapse, most of the patients, when they were put back on treatment, got better again. But after each relapse, there was a subset of patients who became treatment refractory, who never recovered after. Whether it was the first, the second, the third, or the fourth relapse, there was a different subset each time that became treatment refractory. And we were able to look at that. So it was on average 1 in 6 patients. And in the same study where we discontinued treatment, this is what we found in a subset of patients who became treatment refractory or non-responsive. And here you can see when we treated them for their first episode psychosis, a very good symptom reduction, very good treatment response over the first 8 weeks. And the very same patients who had had a relapse, we put them back on treatment, and you can see a very different treatment trajectory. So here we have evidence of emergent refractoriness or treatment failure in a subset, and it was exactly as the Dutch cohort showed. 1 in 6 patients became treatment refractory. So when patients discontinue treatment, and of course in clinical practice it's not like in a clinical trial, most patients, this is a patient-driven decision to discontinue treatment. we have to remember that virtually all of them will relapse. It may occur within days of discontinuation. There are no reliable early warning signs, and there's a risk of emergent treatment failure in a subgroup of patients. So if you want reasons why we should be focusing on relapse prevention, here we are. Our primary aim should be to provide uninterrupted D2 blockade. So, getting back to Kreplin's description of the typical course of the illness with chronic deterioration, and Max Birchwood's description, which there's a lot of evidence to indicate that the aggressive years of the illness are in the first years, perhaps the first 5 years, relapses occurring, deterioration occurring. If we are if we are serious about changing that, we have to be focusing on early intervention and preventing relapse. And the way to do that is by providing uninterrupted treatment to our patients. So, finally, what is the key to successful treatment in schizophrenia? I put it to you, it's very straightforward. It's just a matter of sustained D2 receptor blockade. Thank you very much for your attention.
My name is Nick Stefanis. Thank you very much. It was an extraordinary talk, actually.
Thank you.
I think you put forward many of the issues we would like to sort of implement over here in Greece. But I think there is possibly a huge problem with the dopamine hypothesis. And this was actually raised in the last series, just a few weeks ago. I was the chair of the Drug Abuse Psychosis Dopamine Last Day Conference. And an extraordinary study was presented by Abby Darkham, where people who have schizophrenia, but also take drugs of abuse, do not have an excess dopamine. Actually, they have a reduced dopamine release. And the whole idea about presynaptic dopamine excessive storage and release just seems to be crumbling just because of one study. So the dogma that psychosis is associated always with an increased abundance of dopamine, increased release, seems to be not the case in all forms of psychosis, especially in those young people who develop psychosis who also take cannabis. So it seems one of the paradigm shifts, and Oliver House and many other people are actually really wondering what is going on. Is this a D2 dopamine hypersensitivity instead of this presynaptic dopamine story that we've been adhering for about 10, 15 years? Is actually the real cause of things. It's unfortunate. Professor Jim Van Os was here yesterday, and he was the first one who presented those acting one associations with cannabis and a huge increase of psychosis, and Professor Murray as well. So I would consider it one of the very few replicated studies when it comes to gene-environment interaction in psychiatry. So your comments on this, please.
Well, thank you very much. Absolutely, these are very astute comments, and I must confess I'm very guilty of oversimplification in this presentation, and I know that by just saying it's dopamine, then we obviously it's not going to be as straightforward and as simple as that. The point I'm making is that all of our attempts to look at other possible mechanisms, whether it's been serotonergic involvements, whether it's been the GABA, the glutamate, the NMDA receptors, they've all come to naught, actually, in terms of psychosis. So, and that's why I just feel that as clinicians, we shouldn't be focusing on GABA right now. We shouldn't be focusing on oxidative stress right now. We need to focus on what's working and what's happening, and that is dopamine. So the point you're making, of course, is very, very pertinent. And the two hypotheses that I presented are, in fact, contradictory, because Simon Lovestone says there's a downstream dysregulation, intracellular signaling of dopamine. And Oliver House is saying, no, it's an upstream presynaptic excessive synthesis of dopamine. So how do we reconcile this? And my thought would be that, let's say the Lovestone group are correct. That would mean that what House is describing may be a compensatory mechanism. So in other words, excessive presynaptic dopamine synthesis as an attempt to normalize some dysregulation in the AKT-GSK pathway. That would be just a thought. And of course it's complicated. And I wasn't aware of the fact that with substance abuse you actually get decreased dopamine, and that would just complicate the issue even further, I think. So that's about as far as I can go with an answer to your question. Thank you.
Professor Papadimitriou.
Congratulations for the talk. Your comments regarding the relationship between the dopamine and the refractory cases. Do you think there is resistance and the relation with the dopamine?
Thank you.
Do you think it's resistant the illness or resistant the patients?
Okay. So that is also something that's been of great interest to us, and we've been actually trying to focus on, because we've identified this emergent treatment refractoriness in a subset of patients, and we've been looking at the neurobiology of this, what possible explanation can we come up with in terms of dopamine or something else? And there's only one model that I'm aware of that can explain the phenomenon that we're seeing, that the Dutch group described and that we've now seen in two separate studies. So when patients have a relapse, it's not that every one of them becomes a little bit worse. It's not a thing that happens to everybody. So you either 5 out of 6 of them will get better, but 1 out of 6 will become severely refractory. And the only model that I'm aware of that can explain that is a threshold phenomenon, a kindling phenomenon.
Kindling, yes.
Yeah. So kindling, and with the sub-threshold stimulation, you either get better or you've had it. And that, of course, would implicate, then we would be implicating GABA and oxidative stress.
Glutamatergic system.
Yes. But of course, and just to continue, and then we come to the dopamine supersensitivity model. And that is something that may explain what we're seeing here. Except I'm not able to work out whether it's the continuous D2 blockade that may be the sensitizing factor, or the recurrent discontinuation of patients who discontinue, which sensitizes. Maybe you have a comment there?
Yes. Yes, I agree. I agree with it. There is a kindling, maybe.
Mm-hmm.
But do you think there is a differences, gender differences in this kindling phenomenon? Gender differences between males and females?
A gender difference?
Yes.
We haven't looked at that, so I'm not sure. Is there a reason why you're asking that? Is there some reason why there may be a gender difference?
Yes, maybe.
Maybe. Mm-hmm.
Regarding also the response, the drug response.
Mm-hmm. Mm-hmm.
The pharmacogenetics and...
So I promise I'll go back and I'll look at our results and I'll let you know. Thanks.
Well, can I ask one question about where does clozapine fit in all these hypotheses, and also regarding the fact that clozapine mechanism of action is rather slow, right? Doesn't seem to work in the way that D2 blocking agents work. In the first few weeks, it seems to, keep up for longer times, and you see an effect after 3-4 weeks or even months. How does this reconcile with the prominent hypothesis?
Well, the short answer would be I don't know. But let me give you an attempt. So you'll know that the dopamine receptor binding profile is very complex and very unusual, and that D2 affinity is actually low with dopamine, with clozapine. It has a higher D4 receptor affinity, and we're not quite sure because D4 antagonists don't seem to be effective in antipsychotics. And then it has a whole lot of other things that it does, whether it's muscarinic, histaminergic, alpha-adrenergic, whatever. And I'm not quite sure. And of course, the serotonergic, all of the serotonergic receptors. So I'm not quite sure how to explain the fact that clozapine has a benefit greater than any other antipsychotics in these refractory patients. And maybe here is something that is not linked to dopamine, I must confess. Thank you.